Hi, everyone. Did you know that in every 3 seconds, someone in the world develops dementia? And the prevalence is set to rise with an estimated 75 million people with dementia by 2030. So let's take a step back. What is dementia? Who gets it? How is it diagnosed? And how is it treated, if it is? We'll be answering these questions and more, so stay till the end to have these questions answered. Just as an introduction, my name is Monica, and I'm a graduate student and Psych2Go team member. I host these Ask an Expert series to make psychiatry and psychology accessible for everyone. Today, I invited my friend and expert in training, Rebecca Williams, to chat about these questions. So, welcome, Rebecca.
Hi.
Thanks
Lovely
for
to be here.
joining. Thanks so much for joining the Psych2Go community today with this live stream.
Oh no, I'm really excited to be here.
Do you want to start by giving a little introduction about yourself so the whole Psych2Go community can get to know you a bit better?
Yeah, of course. So hi everyone. My name is Rebecca. I'm currently in my first year studying for a PhD at the University of Cambridge. And specifically, I'm looking for a doctorate in medical sciences, specializing in dementia. So I am an expert in training, but hopefully we'll be able to answer some of your questions here today. And I'm super excited to be here. In my spare time, I also enjoy doing a bit of musical theatre, and I play board games because I am an utter nerd in every sense of the word.
Thanks for the introduction. So, I thought it might be a good time for us just to do an overview. So, for everyone joining us, this is an Ask an Expert series. We'll be covering dementia today. We'll first start by the general what is dementia versus Alzheimer's, and get on all the questions that were submitted to our YouTube community page and our Discord server, which is linked in the description box below. Also like to take this time to thank all our YouTube members and subscribers for allowing this to happen. So if you're really interested in watching more live streams like these, consider joining our membership and subscribing. Now we've got that done. Let's just start with the general question that everyone's asking. What is a neurodegenerative disease and what is dementia?
Yeah, I think I saw one of the comments that was absolutely spot on, where they were saying basically, before we start talking about all these things, we need to know what it is we're talking about, right? What do these terms mean? Because we sometimes use them interchangeably with each other. So generally, when we're talking about a neurodegenerative disorder, this is a big old umbrella term. All we're referring to is disorders in which the brain is progressively starting to degrade. So it's starting to get worse. You might see cells in the brain dying and that kind of thing. And dementia is a type of neurodegenerative disorder. Now, another question that I get asked a lot is, what is the difference between Alzheimer's and dementia? Is there a difference? Are they the same thing? We often hear the two words kind of used as if they mean the same thing, but they're actually a little bit different. So dementia is another one of those umbrella terms that we use to describe a few different neurodegenerative disorders with characteristics impairments in things like cognition, the way we think, in our behavior, in memory, in language, all these things that are going to probably impact how we function on a daily basis. So Alzheimer's is actually a type of dementia. It's actually the most common type of dementia that we'll come across, but there are others. So vascular dementia is another type, specifically associated with blood flow to the brain. We also have Lewy body dementia, which is particularly associated with a different neurodegenerative disorder, Parkinson's disease, can accompany that in the later stages. And the one that I specialize in my PhD, which is frontotemporal dementia, which is often associated not with anything to do with memory, but instead with personality changes and difficulties in using language. So when we're talking about dementia, it's that umbrella term for a number of disorders, and Alzheimer's is a type of dementia. It's the most common type of dementia that we'll see.
What a clear answer. Hopefully it clarifies it for everyone and really sets the tone for the more detailed conversations we'll be having after. So maybe it's a good idea to give an overview of the different types of cognitive impairments that one can expect in dementia, or like the specific subtypes of it.
Yeah, absolutely. So as I say, because dementia is such a kind of broad term, it can refer to a whole host of different types of symptoms. So in Alzheimer's, what we'll often see is memory deficits, so people will struggle to remember things, or difficulties in spatial navigation. They generally struggle to be what we call oriented in space and time. So knowing where they are and knowing when they are can become difficult. They can become maybe confused and disorientated about things like that. The thing I get asked a lot as well is, oh my gosh, my memory is terrible already. I'm like in my 20s, I can't remember anything. Am I going to get dementia? And I wouldn't be any more concerned about you than anyone else. Usually when we're looking at these dementias, what we're looking for is a big change over the course of weeks or months in how people function. So for example, I have a pretty decent memory. So if I woke up a few months from now and realized that I was struggling to remember, for example, my family or just where I put things, then I might be concerned about that. But I also have a completely terrible sense of spatial direction. I have such a bad sense of direction. I get periodically mocked by my entire friendship group about how bad my sense of direction is. So if I woke up one morning and wasn't able to, I was never good at it anyway. So usually with symptoms, what we're looking at is for that change. We're looking for that worsening of these abilities. And I remember one of my professors in undergrad saying, you know, people forgetting that they've left their tea bag in a cup of tea, we're not going to be worried about dementia. But if you're putting the kettle in the freezer to boil it, then it might be time to go see your GP.
Yeah, for sure. And how is that, let's say, different from, let's say, Lewy body dementia or frontotemporal dementia?
Yeah.
Sorry, it's a mouthful.
No worries. So like I say, frontotemporal dementia is the area that I'm looking to study. So it's the one that I'm most excited about. So as I mentioned, usually with frontotemporal dementia, we don't actually see, it doesn't present as memory difficulties. A lot of the time with Alzheimer's, the reasons that people will go to their GP is because they notice their memory starting to fail, or their family or carers or friends start to notice their memory starting to fail. But in frontotemporal dementia, there are kind of two categories broadly. One is a behavioral variant and the other is a semantic variant. So in behavioral variant frontotemporal dementia, which is really rolls off the tongue, so we call it BVFTD, what we're looking for that usually starts off is personality changes. So people can become what we call apathetic. They lose their motivation to do things, which can obviously have big impacts on things like how often they take their medication and also just quality of life, how well they interact with the world around them. They can also become impulsive, so they can engage in kind of socially inappropriate behaviors that they don't realize are inappropriate at all. And in the semantic variant, what we actually get is loss of language. And I find this just absolutely fascinating, is that they forget what things are. So for example, they may look at a cat and say, oh, look, it's a thingamabob, you know, the dog. So they may confuse objects, but they completely lose their understanding and the memory of what certain objects are. So that's more of a kind of semantic variant where we see kind of those language impairments are kind of what it presents as. So as much as we do really kind of associate, because Alzheimer's is the most common, we associate dementia with these memory impairments. Memory is by no means the only thing that can be impacted in dementia. And for certain types of dementia, it isn't even the thing that we would think would be the first thing to be impacted.
Yeah, so with these symptoms that you described, sometimes it's hard to find specific words, for example. This sometimes overlaps with other sort of disorders, right? So one I can think of is, from what you described, like Wernicke's aphasia, kind of like a word salad.
Wernicke's,
It's hard to
yeah.
come up with words. So maybe it's a good time for us to talk about how dementia can be diagnosed and how we can tell it's dementia rather than any other kind of disorder in the brain.
Yeah, absolutely. So it is one of these things that, especially with dementias and with psychiatric disorders like, depression, OCD, anxiety, is what we really want is kind of these clear boxes of, okay, this is what causes this, and this is what we treat, how we treat this, and these are the symptoms of this. But as you mentioned, if only it were that simple. There are a million different things in the brain that could cause the same set of symptoms. And sometimes it's really difficult to know which is causing what and what disorders might be overlapping to cause all these different things. Or is it different disorders? Is it the same disorder? It just gets very messy and very confusing. Usually the way that we will diagnose dementia, and by we, I mean trained doctors and professionals, is with cognitive tests. So if you go to a GP, for example, with concerns about your memory or concerns that you may be developing some kind of dementia, if they think those concerns require a bit of further investigation, they may send you to a specialist, a neurologist, for example, or a memory clinic. And they will usually run a battery of cognitive tests, and they will test a lot of those things that we've just been talking about in symptoms. So they will test things like memory, but also things like language, just basic skills like, are you able to copy pictures over? And there's a whole bunch of different cognitive tests we can use, but we'll usually run people through a series of those. And the other part that we usually see in diagnosis is neuroimaging. So when we talk about neuroimaging, we're just talking about all those kinds of scans that we can do on the brain to see kind of what's actually going on in the brain. So the gold standard that we would like to be able to use for a lot of these diagnoses is MRI, because it's really nice and clear picture. But usually what we end up with is a CT scan, which is just a little bit worse resolution. It's kind of a TV from the 90s as opposed to your HD BBC HD TV. But yeah, so we use neuroimaging to look at, one, which parts of the brain might be starting to degrade. As I mentioned, in neurodegenerative disorders, we might see cells starting to die. We might see parts of the brain starting to kind of wear away a little bit. And in neuroimaging, we might be able to tell which parts of the brain are starting to wear away, and that can help inform us about which type of dementia we're dealing with. So, for example, in frontotemporal dementia, as the name suggests, we would expect that the frontal and the temporal lobes are the ones that start to go first. So if we see that, that might help us confirm a diagnosis or go, oh, maybe we're not quite right there. And the other thing that is useful in neuroimaging is we want to be able to check that it's not because of anything else. So if you have, for example, a tumor in the brain, we want to make sure that this is actually caused by dementia. It's caused by dementia, not caused by something else that we could maybe fix with a completely different set of treatments. So usually use those cognitive batteries, maybe some behavioral tests will get you to do some tasks, and then some neuroimaging is usually what we'll see for a diagnosis of dementia. But sadly, like I say, it can be confusing. It can be a really uncertain time for a lot of people getting a diagnosis or having the diagnosis changed. But generally, it can be, I think, really helpful for people to kind of have that label of, okay, I think this is what we're dealing with, can provide a little bit of certainty in what is quite a tumultuous time in life, and also can help us inform what treatments we think would be best going forward.
Yeah, I think from your answer, it speaks to the importance of having many different kind of ways to look at it. So you said looking at using MRI, perhaps using cognitive tests. There's the MoCA, Montreal Cognitive Assessment as
MoCA,
well.
ASAR. There's a whole bunch of those.
So it's not relying on one single thing, because it's just so hard to come up with a diagnosis from one thing, right? So yeah, definitely. In terms of the importance of looking at family history, do you want to comment a bit about that aspect? How heavily weighted is that taken into consideration?
Yeah, absolutely. So I think there's another thing that I saw mentioned was genetics. And basically with a lot of these dementias, when we're talking about things that can contribute towards them, we're never talking in absolutes. It's very rare cases where we say, okay, you have this gene and you are going to get this dementia. We do it with some disorders, like Huntington's disease is a good example. We can do genetic testing and say, all right, you have this gene. At some point in your life, you will develop Huntington's. There are some very rare cases where that is true of dementia. We can say you have this gene, you will get this dementia. But in the vast majority of cases, we're dealing with risk. We're dealing with genes that will increase your risk, increase the likelihood, the probability that you will develop these dementias. One of the most common examples that we see in literature is the APOE4, which is linked to Alzheimer's. And if you have this particular variant of this gene, it increases your likelihood that you will get Alzheimer's. And there's some really interesting, I think, Monica, you were here for these lectures, and we were doing about looking at genetic testing and kind of publicly available genetic testing, where you can now test your own genes and see if you have this particular variant. And we were having a really interesting discussion in one class we had about how valuable that was without proper interpretation, and how that could scare people without knowing that, no, this is just a risk factor like anything else. And I think there was some other things about kind of lifestyle and how that can impact your likelihood of getting dementia. Again, all dealing with risk factors here, no absolutes. But there was a really interesting paper that was published last year, I think a couple of years ago, by a researcher called Livingston, which is a really kind of lovely read, which highlighted a whole myriad of potential lifestyle factors that could increase your risk of getting dementia. It's nothing really surprising or new. It's the stuff we all know, we just don't do it. It's eating healthily and making sure you get exercise, not smoking, things like hypertension and kind of obesity being linked with dementia in some cases, but also social factors, things like social isolation were linked to dementia. So I think it's always worth bearing in mind, dementia is associated with being older. Age is probably the biggest risk factor for dementia. I think it goes from something 1 in 16 over 65s will have it, compared to 1 in 6 over 80s. Age is a big risk factor. But just because people hit 60 doesn't mean, oh, yeah, that's it. Now you're going to get dementia. Your time is done now. No, engage people, please. You don't suddenly become obsolete when you reach a certain age. You are not guaranteed to get dementia. There are some people who will live into their 90s, 100s, who will never get dementia. So engage people, keep people out of that kind of social isolation bubble. I think from the last year of COVID, we all know at this point how important it is to just have interaction with people. So keep doing that, because social isolation was one of the things they highlighted.
Yeah, I remember reading that paper as well. It
It's a
mentioned a
really good
couple of
paper.
interesting environmental factors. I think
Yeah,
one of them was depression, actually.
depression
Again,
as
for those
well.
watching, it's not like if you have depression, you will get
No, please,
dementia,
please
but
no.
yeah.
It's really interesting actually, because it was specifically late life depression that they said. So there's a bit of an issue there with going a little bit more technical, but not too much, I promise, Monica, is that with a lot of dementias, before you get a diagnosis, there's a period called a prodrome. And that's a period in which we might see the brain start to degrade a little bit, but not enough for you to go to a doctor and then go, oh, yes, you have Alzheimer's. And one of the theories is that depression, instead of being a risk factor, is actually a part of that prodrome. So it isn't increasing your risk of getting dementia if you get it in late life, but it's actually a sign that it may be upcoming almost. So there's some really interesting debate around kind of cause and effect of these risk factors, which ones are actually increasing your risk versus which ones are linked to the Alzheimer's or dementia, but years ahead. It's a really interesting chicken and egg situation with a lot of these things.
Yeah, speaking of the prodromal period, I don't remember if it would be how early do people kind of recognize it? I know there's
Oh,
some like pathological things before, right?
yeah, this
But
is one of my favorites. So
yeah, yeah, let's
I'm
chat
gonna
about that.
deviate slightly into Parkinson's disease,
Yeah.
because this is one that I've done a research project on, and that I know a little bit more about in terms of the prodrome. So Parkinson's disease is not classified within dementia, because it is primarily a motor disorder. And what I mean by that is it has the characteristics are what we call tilt rolling tremor, so your hands are shaking. You also have postural instability, so you might like to fall over, losing a bit of your balance, and you have bradykinesia, which means you move slowly. And like I say, to get a diagnosis of Parkinson's, you need these motor symptoms. But some people estimate 10, 20 years before, we start seeing issues in sleep is a massive one. They kind of highlighted as one of the best predictors of Parkinson's is a sleep disorder called RBD, which is REM sleep behavioral disorder, which basically means normally in REM sleep, which is a period in your sleep when your brain is as active as when you're awake. And for that reason, your brain kind of cuts off your body and kind of paralyzes you because it's active and it doesn't want you to act out everything that's going on. So obviously sleepwalking more in children is it's not quite got that paralysis right yet. So they're acting some of it out. But in REM sleep behavioral disorder, you kind of lose this altogether. So your body, your brain stops being able to kind of paralyze at the right time in REM sleep. So you start acting out your dreams and you can start lashing out. And like I say, that can be 8, 10 years before any motor symptoms start. And again, this is all risk. Just because you have any of these things is not a guarantee at all that you will develop anything later in life. But yeah, like you say, these prodromal phases of disorders are a really interesting part of research for me, of looking just how far back we can start tracking things is really fascinating.
I wonder if anyone is interested in more of the neuropathological kind of biological things with that
Yeah,
people find in Alzheimer's in the chat. If you're interested, then type it. We'll see, and we can go in
yeah,
a
I'm
bit of
happy to
like the
go. I'm
surface
happy
of
to go
that.
neuroscience. This is
Because I feel like it's such an
where I'm at.
interesting conversation, you know? And
It's so much fun. I love brains. It's the reason I do the PhD I do.
I think, yeah, why don't we have like a little overview of the kind of neuropathological features that typically is in a brain of someone with Alzheimer's or with frontotemporal, you know,
Yeah,
dementia, these
yeah.
kind of things. And hopefully it's interesting for those watching.
Yeah, so Alzheimer's is kind of the big one where we've identified obviously multiple stages, and they're called BRAC stages, BRAAK, after the researcher that kind of started mapping in these various types of dementias and various neurodegenerative disorders, which brain areas are affected first. So we have kind of hypotheses of, we know this brain area kind of does this and this brain area kind of does that. So based on these symptoms, these are the brain areas we'd expect to be affected. But yeah, BRAC really kind of mapped these stages of degeneration. And again, it doesn't mean that it's applicable to everyone. It's a general rule. And to some extent, when you're dealing with people, general rules will only get you so far because people are inherently different and everyone is individual. So just because someone who has Alzheimer's develops in this way does not mean that someone else with Alzheimer's would develop in the same way. But we have these kind of broad things of what we expect to happen first in the brain, which brain areas we expect to be hit first. By pathologies. And we're talking about pathologies, again, we see kind of specific types of pathology in brains with different types of dementias. And this is kind of one of the clinchers, is that, as I was mentioning with diagnosis, it can be difficult to settle on a diagnosis when we're using all these cognitive behavioral neuroimaging tests. And actually, at least correct me if I'm wrong, Monica, the only way to actually confirm a diagnosis is post-mortem, is after death, because then you can look at the brain and find these pathologies and you go, aha, now we know they're there. We definitely know they had this disorder. So that's kind of the most concrete way we have right now. But obviously, we'd rather diagnose them when they're living and can be helpful. But in Alzheimer's, the kind of key pathologies we talk about and that you might hear about is amyloid beta plaques and neurofibrillary tangles, or NFTs, are kind of the pathology that we see associated with those. With frontotemporal dementia, it's more kind of tau pathologies, and these are kind of proteins in the brain. So a lot of what we talk about is we call misfolded proteins. So usually in your brain, it's pretty good at doing what it needs to do. But in dementia, that starts going wrong. Things start getting a little bit haywire. These proteins that should be folded in a certain way aren't so much anymore. And therefore, instead of doing the functions that they should do, they start to mess with functions instead. You start to get loss of functions because of this. And it's one of my, again, I'm a big advocate of sleep, both for myself and for other people. Sleep's great. And so I say sleep is one of the first things that we see to go, not only in neurological disorders, but in, psychiatric disorders. And it's really interesting to me to how sleep interacts with all of this in terms of, I think it's when you sleep, the fluid in your brain moves about twice as quickly when you're asleep, which means it can clear out all of these misfolded proteins or these things in the brain that aren't quite going right. It can help clear them out a little bit. So if you aren't getting enough sleep, or if sleep starts to go, then that kind of what we call proteostasis, the balance of proteins in the brain, can start to go a little bit awry. And obviously there's many other factors and many other mechanisms in the brain which will help maintain that. But yeah, I find sleep absolutely fascinating. If I hadn't gone into kind of the clinical side of things, I would definitely be researching sleep. I think it's an absolutely fascinating process of how it links with everything. But yeah, so we see vaguely different pathologies in different types of dementia. Like say in Alzheimer's, we'll see things like amyloid beta plaques, neurofibrillary tangles, and again, at different stages in different brain areas. Whereas in conditions like FTD, we may see things more closely linked to other proteins like tau. But yeah, I fully encourage you to go and do more research on that, because it's not an area that I am particularly well versed in. So feel free to get on Google Scholar, or my favorite is PubMed for kind of academic journals. Not all of them are free, I will grant you, but there's a lot that are. And it can, once you can kind of get through the babble, the kind of neuro babble, they can be really interesting to read them for yourselves, and also to be, critical of, do you actually trust what these people are saying? Did they use enough participants? Are they using logical fallacies? I find a really fun part of my research is, finding these articles and seeing if I trust them.
Yeah, for sure. And I like how you mentioned the fact that diagnosis is typically made, well, certain kind of diagnosis is made post-mortem, so
Yeah, it's
after someone
confirmed,
has
yeah.
died, right? And that really speaks to the interesting fact that most dementias are actually misdiagnosed. I remember in the
Yeah,
slides, like,
it's a whole thing, right? It's
yeah,
especially in like research, is it can really mess with us in research. Because if you're doing, for example, a drug trial and you're trying to see if this particular drug is effective in Alzheimer's, for example, and you do your study and you find, it's not effective, it's not significantly better than a placebo, what are you going to do? But if actually, you have a percentage of those Alzheimer's patients who have actually been misdiagnosed with Alzheimer's and actually don't have the pathology of Alzheimer's that you're trying to target with your drug, of course it's not going to work with them. So it becomes a really interesting, like you say, question in not only on a personal level of the effect that being misdiagnosed can have, but also at a research and academic level of how that can mess with our studies, because you start including people that don't actually have it, which can cause a few issues. But yeah, it's really interesting.
Right. And then going back to your point about kind of critically assessing scientific literature. So this is
Mm,
something to keep in mind when reading
yeah.
papers about dementia. You have to think like, oh, is there a possibility that someone might be classified as having Alzheimer's, whereas they might have vascular dementia, for example? And
Yeah. And like I say, it's something I really enjoy doing. I think when I first started reading kind of scientific papers, somewhat, validly, when I didn't understand something, I was like, oh my gosh, I just don't understand what's going on. And obviously, when you start out, that's probably true. You probably don't understand what's going on because you are young and don't understand. But increasingly, as I learn more about the topic, it becomes easier to be critical of papers when I read something and I'm like, that doesn't make sense. Now my first thought is usually not, oh my gosh, I'm so silly, I don't understand this. It's, okay, why doesn't that make sense? Is it because I don't yet have an understanding of this topic? Or is it because they're making logical leaps that don't quite follow? Or is it because I don't think that based on their results, they can actually say that? So yeah, it's like I say, it's something I really enjoy. And I try and teach to my students when I have them is, to be critical of papers in the right ways, to be critical of the papers that you read. Don't just distrust everything because you don't know the person who wrote the paper. But have a look. How did they use like 2 participants in the study? In which case, maybe not so much. Or they say, are they making weird logical leaps? Have they got confounding variables of things they're like, well, that might not be caused by that. It might be caused by that. Science is definitely one of those subjects, as with many things, is that the more you learn, the less you know. The more you read around, the less we are certain of literally anything.
yeah, and so that also speaks to the importance of just using many sources and not just reading
Yeah,
something from one
absolutely.
perspective, right? From
Yeah.
assessing.
Use your meta-analyses. Has it been repeated many times?
Yeah.
Is it replicable? Like, is it, are there big papers where they've gone, oh yeah, we've had hundreds of participants doing this? Like, yeah, it's a really interesting, as I say, as I've started my PhD, we've had a lot of, obviously, as we're younger researchers and they want to get in before we get any bad habits set up, they've been teaching us a lot about good scientific practices. So yeah, it's a very interesting kind of the science of science, I suppose.
For sure. And I think this is actually quite interesting. So if any of the Psych2Goers are interested in
Yes.
kind of assessing scientific data, how to make sure that what you're reading is actually accurate and can be used as a basis for future learning, then comment in the live chat because then we can definitely do a session about that. I think it would be really interesting.
Yeah.
Yeah. And okay, so we've talked a lot about dementia in general, but we've, of course, talked about the specifics. And I think a lot of people are asking about the treatment aspect of it, right? Because
Yeah.
I can read right now that people are like, oh, what happens if I get dementia? Is it preventable? So why don't we chat about the treatments? Is there
Yeah.
a treatment? Well,
Yeah.
spoiler,
So
no, but
spoiler alert. Okay, I'm gonna start with the really bleak stuff, but then I'm gonna get better. So just hang with me through the bleak opener, and I promise it will get better. So we do not have a cure for dementia, and by that what I mean is if you get dementia, there is no current way to reverse that. We can't give people a drug or a treatment to stop people getting dementia, and once they have it, we don't have anything that can help slow it down. Now, with that one, I'm going to put a slight pin in that, though, and I will come back to at the end. But at the minute, there's no cure for dementia. So when we talk about treatments in dementia, what we're really talking about is symptom management. And by that, I mean, we're not going for the root cause of dementia. We're not going after what has caused all of this. We're going after kind of the downstream effects. So for example, if you break your leg, I cannot wave a magic wand and make your leg unbroken. Sadly, as lovely as that would be. I can't do it. But what I can do is I can put your leg in a cast, I can give you some painkillers, and I can give you crutches. So even though your leg is still broken, you can still walk around, live pretty independently, and you're not in pain. Your quality of life is higher. So what we're trying to do with this symptom management is make sure that people can independently function as much as possible. Keep them in their own homes, keep them with family members as much as we can, and also to improve that quality of life, to make sure that they're enjoying themselves as much as can be done. So we can do that with drugs, is obviously a key method that we use. We can also do it with surgeries a bit more rarely, but this is, again, it's something that even though I know how it works. Nobody knows how it works. It's still just utter witchcraft to me, is deep brain stimulation. So if you haven't seen videos of this, I fully encourage you, just go and search for DBS in Parkinson's disease. But basically what happens with this is electrodes are implanted into the brain to stimulate the parts of the brain that are starting to die off. So to kind of try and compensate for this loss of cells. And what we see from that, I say, in Parkinson's disease is where people were previously really struggling to get up and walking really slowly and struggling to turn around, are suddenly just strolling along. It is absolutely, it will never not be astounding to me. And I think it's being trialed for, you know, other conditions at the minute. OCD and anorexia, I think, are ones I've seen papers on to see if it can be applied to different things. But it's just absolutely magic to me. And it's always one of those things that I see and I'm like, that's why we do research, like that kind of improvement. And like I say, it's not magic. It doesn't work for everyone. It isn't suitable for everyone. It wouldn't be recommended for everyone. But in those people it does work for, oh my gosh, it's so amazing to see. And we also have, obviously, moving away from kind of the biological side, we have non-pharmacological treatments like therapies, music therapy, memory therapy, even doll therapy is one that I was reading about, which I thought was really fun, where they've been giving kind of people in care homes dolls to take care of, obviously kind of trying to tap into that maternal or paternal instinct, I suppose, that they may have, that was shown to improve their kind of functioning quite a bit, which was quite a fun one. But yeah, so as much as obviously as a neuroscientist and as kind of someone who focuses on that biological element of things, it is easy to get caught up in, okay, what drugs do we have? How can we fix the brain? How can we do this and this and this and this? We can never forget the value that comes in other forms of therapy, not only for the patient, but also for their carers, for their guardians, for the people that are taking care of them. So for example, memory cafes are something that operate up and down the UK, where people can go and you know, talk, and it can be really, I think, valuable for people who care for those with dementia to meet other carers. Because it's something else I saw commented on, you're absolutely right, is that it can be really difficult to be a carer of someone with dementia. Things we haven't talked about is other symptoms of dementias can be what we call neuropsychiatric. So they can become, for example, really agitated, or they may have delusions or hallucinations. They can get aggressive sometimes, or sometimes just, like, say, very confused. And I think it's really important to take care of the carers, because we also see that kind of the health of the carer does impact the health of the person they are caring for, which makes good logical sense. So as much as they say a lot of this research and a lot of what we're talking about today is focused on the people who experience dementia and what is going on with them, we can never forget about the people who care for them, and what they're going through, because they are, I think it was the Livingston paper that said they're the most valuable asset that we have in caring for those with dementia. So yeah, we have kind of the drug side of things, in very rare cases, kind of neurosurgery, and non-pharmacological therapy and treatments. Now, the pin that I put in about we cannot slow down dementia, I'm going to take that out now, because earlier this year, the first FDA-approved drug was released that was said to slow down Alzheimer's disease. Now, this was huge. There was a whole lot of debate around this about whether we thought the evidence was sufficient, that it would be effective, would it actually work on a big scale? And we're still kind of waiting for those longer term results to come in on that. But that is obviously quite it's quite exciting. And so I'm also on the fence of, I'm like, oh, I don't know if is it going to work? Is it not? But there's also, you know, so much coming down the pipeline at the minute of similar things. And it's going to be really exciting over the next 50 years. It can be really exciting to see what happens when it comes to treatments for dementias. You know, people forget, I think, that neuroscience is still a very baby field. Like, we are a baby science. We've only been around for a little while. Please give us a second. Like, I had a talk the other day by, I think, the longest serving member of my department, who was saying that, you know, in his career, in his academic career, neuroimaging was basically invented as a thing. They thought it was crazy that you'd be able to see the brain. You're like, oh my gosh, PET scans? What are you doing? You're throwing your career away. You can't do that. And then it worked. And people were like, oh my gosh. So we really only had these kind of neuroimaging techniques. We can see the brain for about 30, 40 years. So it's still a baby science. There is so much going on. It's a super exciting field to be in for that reason. So even though right now, like I say, it starts off pretty bleak, as there isn't really a cure for dementia. But we have so much technology now that we didn't used to have. And increasingly, we have phenomenal technicians and biologists and computer scientists and researchers all working together and collaborating to generate even better technology than we had before. Like I say, some of the things that I've been introduced to at the start of my PhD is things that are possible still just absolutely blow my mind. MRI machines are still something that I look at and I'm like, what? Who thought, how we'll look at the brain? I know, we'll use a really big magnet. Like what? Who? Why? So we do not have a cure for dementia currently. The things that we use is symptom management using mostly drugs and non-pharmacological therapies. But over the next 50 years, it will be really interesting to see what comes out of the research pipeline.
Definitely. What a great answer. So comprehensive. And it really touches on the interdisciplinary nature of it, right? So we're
Yeah, it's
not
really
just
important.
relying on neuroscientists, but perhaps biologists,
Mhm.
computer scientists. And
Yeah.
it's super exciting to see what's ahead for neuroscience and psychiatry.
Yeah,
So
absolutely. Yeah. If you don't like coding, don't get into neuroscience. I thought I could escape coding, but nope. Computer scientists are the bread and butter.
yeah, especially with the importance of coding, right?
Oh,
So,
yeah.
and the whole field of computational
The
neuroscience,
whole
like
field of computational neuroscience. Yeah.
exactly. And so let's go back to the importance of, supporting those who are supporting those with dementia, because that is like
Mhm.
a very important part. And for many people who are wondering right now, what is the best way to support someone with dementia and support those who are supporting those with
Yeah.
dementia?
Yeah.
Any
Yeah.
thoughts? What do you think?
Yeah, so it's obviously a really interesting question, and as someone who is obviously young and hasn't been in either of those positions, there's a limit to how much I can say that will be of value. But I've also had family members who have been through dementia and kind of seen kind of firsthand what that can be like for them. So in terms of caring for people with dementia, it's the same old. I think just being there for them can be really useful. I know it can be really frustrating or upsetting, especially you see comments of like they don't remember me anymore, and that is, don't you? I've been there. It is absolutely gut wrenching, but it's the dementia. It's the disease. In terms of caring for the carers, I think, like I say, just listening. It's one thing that I'm a big fan of, both as someone who has done kind of mental health awareness and in this field, is actually just listening to someone is so powerful, because there's so often when we're having conversations, we're not truly listening. We're thinking about what we're going to say next, or we're thinking about what we're going to have for dinner. So to actually have someone fully engage with the sole purpose of just listening to you and hearing you out can be a really powerful thing to do. So obviously supporting, give them a weekend off, give them a day off, give them an evening off, but also just listening, because it can be a really complex thing to go through if you are a carer for someone with dementia. There's a lot of kind of mixed mash feelings there to try and work through, like I say, of confusion and kind of like anger of, why don't they remember me? But then knowing that they can't remember, it's not them, it's not their fault they don't remember you, and they feel guilty about that because there's a lot going on. So yeah, I'm always a fan of just listening. But like I say, that's something I'm not an expert in because I haven't been there. But I think memory cafes as well. If you have a local memory cafe, they can be really useful places for people with dementia and for their carers to meet up and find a bit of solidarity with each other.
For sure. So I volunteer with someone, caregiving for someone with dementia. And one thing that we're often told is that we should also set time to express sometimes how we feel, right? Because it can be
Yeah,
quite
yeah.
heavy and could be quite sad. So taking time to be proactive about one's own health when times might get stressful or when things
Mhm.
are kind of emotionally charged is also a really good outlet for
Yeah,
just taking care of yourself and taking care of
absolutely. You
others.
say you cannot pour from an empty cup, right? If you
Mhm.
are spent, if you are burnt out, there's only so much you can do for other people. So self-care is sometimes the best thing you can do to care for others. I absolutely agree. Yeah, it's a really difficult situation to be in.
And along that idea of interesting things that you can do for someone with dementia, I think actually specifically Alzheimer's, I remember seeing a clip of some man being played music and
Oh my gosh,
be
yeah, music
in our
therapy is
lectures
lovely.
actually. He was being
Yeah,
played
yeah,
music or he was playing music and it was as if all the memories of how to play, like the emotions associated with the music just came back. So
yeah. It's
let's
mad,
just
isn't
talk
it?
about the power of music. It's just
Honestly,
incredible.
it's so cool. I've seen, a few videos of you've got people who are in their 80s, 90s with pretty severe, Alzheimer's or different types of dementia. And there's one old lady that I always remember, and I think it was at the end of a lecture, and it was obviously, it can be a bit bleak when you're getting told about all of this kind of stuff. And I think the lecturer was like, okay, I need to send them out on a high note here. And she put on this video of this woman who, let's say, was really old, and she sat down at this piano, and her daughter was recording her, clearly knowing what was going to happen. And I just went, go on, Mum, just play something. And this woman was like, oh, okay, but I don't remember it. And then suddenly she was playing like the full Moonlight Sonata. Like it was like, and it, like I say, it just baffles me. And it like I say, it's not something I'm well versed on, is music therapy, but I think like I say, it's the idea that you can kind of bypass the areas of the brain that are deteriorated, because music uses slightly different pathways. So it can, it's like I say, music and memory therapies, I think are really interesting. And like I say, as a neuroscientist, it is really easy for me to get bogged down in the kind of the biology, drugs, yes, things that will help. This will help. But yeah, non-pharmacological therapies can be super useful for quality of life. Yeah.
Definitely. I'm a huge proponent of this holistic wellness aspect, just looking at biology, but also, the social aspects of it. Of course, it's really important to touch upon these in our live streams. So it's wonderful that we do. I think for the last 5 minutes or so, it'd be great to hear more about your work as a PhD student. What does it look like? How are you enjoying it? Just for
Yeah.
anyone interested in perhaps going down this field.
Yeah, absolutely. So like I say, I have just started my PhD at Cambridge, which has been really fun so far. Completely different to kind of my undergraduate and my master's degree. It's kind of been a whole different world where I have a little bit more freedom to kind of do the things that I want to pursue. But as I mentioned, my specialty is in frontotemporal dementia, and specifically in that apathy I mentioned, that kind of loss of motivation. The way I describe apathy is your get up and go, got up and went is always my go-to. You just you clinically just don't want to do things. So specifically what I'm looking at is that, and looking at, they say, at a computational level, using a lot of models to see if we can figure out kind of at a cognitive level, what in people's thinking is going wrong to make them apathetic, to make them lose all this motivation. And then linking that, again, let's say holistically, to that even higher level of, okay, what is going on in the brain that is causing these thoughts to happen? Well, consciously or unconsciously, these cognitions to happen, which is then causing apathy, and trying to mark it across all of those levels to get that more complete understanding of what's going on. And obviously the idea is that if we can understand what's going on in the brain that results in apathy, then we might be able to try and correct it with drugs. Or with alternative techniques to try and correct it and improve the apathy. And because we know that apathy is linked to a lot of outcomes, and obviously quality of life quite a bit, it would be nice if we were able to modify that a little bit. But yeah, if it's, like I say, it's completely different to kind of my undergraduate degree, which is all that kind of learning things, kind of content learning. This is all kind of skills, and it's been really fun to just sit and read for a few weeks, and I've just gotten back into my coding again, kind of dusting off my old coding skills to see if I can still remember how to do it. But yeah, so that's kind of what my PhD involves, is using a mix of those neuroimaging techniques along with kind of the computational coding of how is the brain thinking about these things, and linking that to the symptom of, all right, how does that all link to apathy at a concrete level?
That's super wonderful. Thanks for sharing. I'm sure many people are also very interested. So if you have any resources for people to maybe take a further look at, you can also share that. I'm happy to post it in the description box for everyone to take a look after.
Cool.
So apart from that, let's see. We covered in summary what is dementia. It's an umbrella term. For some cognitive range of symptoms for cognitive impairment. We've talked about the specific types of dementia. We've talked about Alzheimer's. I think we talked about, of course, frontotemporal dementia, Lewy body. We touched upon vascular dementia. Then we talked about who gets dementia. Don't worry for anyone young, like less under
Oh yeah,
65.
that really hurt me. It's like I say, it can happen below 60, but it's way more likely over the age of 65. I don't want people really stressing about it.
I really see it in the comments right now. So yeah, it's usually over 65. There's some young onset, but I think even the youngest person who has had dementia was like 30, 27,
Yeah, it's
30.
still, yeah.
And then we talked about kind of risk factors being genetic and environmental ones. Again, emphasizing the fact that if you have one, like perhaps the APO gene, it's not like you are going to get
Yeah.
dementia.
Yeah,
It's
and
just
even all of
a
that
risk factor.
combined, we still don't know what really causes causing it. Even all of those combined may not cause dementia. So we're still trying to figure that one out.
Yeah, exactly. So just the importance of know that if you have one of these risk factors, know that it's a risk factor. It's not going to cause dementia. We also talked about how it's diagnosed. So looking at symptoms, looking at history, looking at MRIs, going to your GP, doing memory tests, things like that. And then we talked about treatments. While there are no disease modifying treatments, there are very exciting avenues ahead. And we touched briefly on how to critically assess the kind of information that you read. So we've really done a huge,
We
tour
come for a span here.
about dementia. And yeah, to finish off, we talked about your work as a PhD student, and that was essentially the whole overview of dementia. If there's anything that people want to know more about, then let us know in the comment section, and
Yeah,
we'll be happy to do another session on this.
yeah, absolutely.
And with that, thank you so much for joining, Rebecca.
No worries. It's been great.
Thanks for sharing your expertise, and thanks to the Psych2Goers for joining us.
Yeah,
If
thanks
you'd like
everyone.
to subscribe, you can subscribe for more of these Ask an Expert series that happen. Also, become a member to make these happen as well. So, yeah, thank you so much.
Great. Thanks for coming, everyone.